Hello, my name is Andrew Ustianowski. I'm an infectious disease consultant based in Manchester in the northwest of England, but I also have other hats. I work for the National Institute of Health Research as the Joint National Lead for Infection, and I also am the National Clinical Lead for the COVID Vaccine Research Programme. But today I'm going to be talking about vaccination and MS. I'm going to sneak in a few other things actually when I'm talking, which I hope you don't mind. These are my disclosures. There's nothing really relevant to this talk. So let's base this on a chap we'll call Bob. Bob is one of your patients with MS, and perhaps you've known him for a while, and we're really going to base the screening, the vaccination and the advice on someone like Bob. So think of him. What I want to touch on is really, why is vaccination relevant to you anyway, as MS nurses and people who work in MS teams? Briefly, screening for infections, which I know isn't in the title, but it does dovetail with vaccination. And then vaccination. What types of vaccination do we have? What are the potential problems? What are the general advice we'd give about vaccination? I've got to touch on COVID, as that's probably the most topical vaccines at the moment. And then travel vaccines, and lastly, other travel advice, which isn't strictly speaking vaccination. So why is vaccination relevant to you as someone who works with MS? Well, some of your patients are going to be on biologics or other immunosuppressants, maybe even high-dose steroids. And these themselves can influence vaccination, either the efficacy, the effectiveness of the vaccines, or perhaps even contraindications, which I'll come to. But also, you'll know as a specialist in an area like MS, you'll often have individuals coming to you with all their health problems and all their health questions, even if they're not directly related to the MS. So you may well be one of the portals of call, or the ports of call, for advice on what vaccines someone should have. Let me touch on screening first though. Screening is really important. So let's pretend Bob, your patient, is about to start immunosuppressants. Are there different tests or investigations you could potentially do prior to commencing that immunosuppressant which may help? Well, the answer is yes. Screening for tuberculosis is vital, and I'll come to that in a second. I would argue everybody needs testing for bloodborne viruses, particularly HIV and hepatitis B, and I'll hopefully justify why in a second. And actually, if anyone's ever travelled or spent significant time in the tropics, I'm very interested in screening them before immunosuppression, and I'll just touch on that. But we can always come back to any of these factors in questions later on, if you like. So, tuberculosis. What can we do? Well, the first thing is to work out if someone actually has active tuberculosis before you start immunosuppression. Do they have any symptoms like a chronic cough or weight loss or fevers that aren't explained by anything else? If so, then someone needs to consider that they might have an untreated infection, including tuberculosis, and that might involve screening them with chest x-rays, asking for sputum samples, etc. But that's going to be a rare occurrence. Most of the people you're going to be starting on biologics or immunosuppressants are probably well from an infection point of view. Now, it doesn't mean, though, that they're not at risk of tuberculosis. About 1 in 3 of the population of the world have been exposed to TB at some point in their lifetime, and the TB is latent or sleeping within them. And the risk is, by starting immunosuppressants, you might reawaken it. So how can we look for latent tuberculosis? Well, don't worry, I'm not going to be talking about lots of immunology. This is really for me to talk over. There's 2 main ways that we can test someone to see if they've been exposed to TB and therefore have an increased risk of reactivation of TB if you're immunosuppressing them. The first is skin testing. You may well have had MON2 tests or HEAF tests when you were younger, and we still do tests like that, and it's really injecting little bits of protein from TB and relatives of TB and seeing if you react to it. But there's more modern ways of doing it, and there's what's called the IGRA test, or the interferon gamma release assays, which you may well be doing, which give us an equivalent answer about whether someone has been exposed to TB. And if they have, then what they really need is they need some tablets to eliminate TB. It doesn't have to be full TB therapy. It can be 3 months of just rifampicin and isoniazid, but it's best to start that at least at the time you're starting immunosuppression, or preferably just briefly beforehand. You don't have to wait for the treatment for latent TB to complete before giving immunosuppressants, and so this really shouldn't delay things more than a couple of weeks or so. What about hepatitis B? Now, it is important when you're thinking about immunosuppressants to know someone's hepatitis B status. Hepatitis B is quite a complicated disease with, people can be active or inactive, they can have resolved infection, but they can have these things called flares, which is when there's sudden inflammation of the liver, and that can cause a lot of problems, and they can reactivate. So even if someone cleared their hepatitis B decades beforehand, if you immunosuppress someone, they could reactivate, and the hepatitis B could then be a problem again. This is an example of what happens, and this is one of the earlier reports on immunosuppression. So it was someone who was given rituximab, and rituximab is an anti-B active biologic, and actually the B cell activity is really important to suppress hepatitis B. So here we had someone who was negative for hepatitis B and had resolved it probably decades beforehand, was given rituximab, and suddenly they got problems with their liver. Their ALT, their AST went up, and actually their hepatitis B viral load went up, and their hepatitis B surface antigen, one of the tests we use, appeared and became positive. So this is what we want to avoid. Well, how can we avoid it? Well, luckily there's nice guidance on what to do in hepatitis B. And it includes a package, a little area, about what to do if you're thinking about immunosuppressants. And basically what you need to do is you need to test for hepatitis B. You need to do what's called the surface antigen, and if that's positive, do a viral load. Even if the surface antigen is negative, we want to know if they've been previously exposed, and that's something called core antibody. And I won't go through this in detail, but depending what biologic you're going to be using, what immunosuppressant you're going to be using, you may want to actually treat someone who otherwise doesn't need treatment for hepatitis B, or give them a prophylaxis, an agent to keep things suppressed or prevent reactivation. I think the issue is if you have someone that you're wanting to start on immunosuppressants and there's evidence of current or prior hepatitis B, then get some advice from your hepatologist or your infectious disease colleagues. What about HIV? Maybe that's coming from left field for you. Why am I talking about HIV? Well, there's a public health message I want to give, and then there's something a bit more specific. So, HIV is nowadays compatible with a normal life expectancy. If you can see there's a blue line and a red line. The red line is group 1, that's people with HIV, but no other major risk factors, no comorbidities, doing reasonably well. And the blue line, group 0, is the general population, and this is in Denmark. And the life expectancy is matched. But that's only if you diagnose someone with HIV. So you can put them on the therapies they need. So that's why I think everybody needs an HIV test, because even if they've only got minimal risk factors, if we find they've got HIV, we can give them a normal life expectancy. And it's not just a normal life expectancy, but if we find someone has got HIV and we put them on treatment, they actually become undetectable in their blood for HIV, and that means untransmissible. So they can have unprotected sex or whatever else, and they're not going to transmit HIV. So public health wise, I think everybody needs HIV testing so that we can put them on treatment for their own benefit and for their partners, etc. But actually more relevant for what we're directly talking about now is your immunosuppression could make things worse if they've got HIV as well, and we don't know about the HIV. And interestingly, it may well be that HIV is the cause of the problem, and actually they haven't got MS at all. So Bob could have HIV and doesn't have MS, but gets exactly the same kind of pattern because of their HIV. So they all need HIV testing. And this is just a worm. I like worms because I'm an infectious diseases doctor. This is one of the few worms that can auto-reinfect. In other words, most worms that you might catch actually need stages outside of you, in soil or in water or whatever else, before they can infect you again. Strongyloides is the exception. And if you immunosuppress people, they can get overwhelming infection, which involves the lungs and the gut and a variety of organs with this worm. It's very rare, but if someone spent a lot of time in the tropics and you're wanting to immunosuppress, maybe have a chat with your local infectious diseases team. A simple blood test can tell you whether they've been exposed to strongyloides or not. Anyway, the real theme, what I'm supposed to be talking about, vaccination. So surely it's a good idea. vaccination is out there, we wouldn't have vaccines unless they were good. And that is undoubtedly true, but I think in the setting we're talking about now, MS, potentially someone who's on biologics or immunosuppressed, perhaps even not, there are two different things we need to think about. Will the vaccines work? And could they cause problems? So, we'll come back to that in a second. The main vaccine types. Vaccines can be prepared in a variety of ways. They all work the same way, which is really to fool our immune system into thinking it's been exposed to that infection. Now, that could be by using what's called a live attenuated vaccine. That is the bug, and it's been changed, so it can still replicate, but it isn't so virulent, it isn't so aggressive. And that would be examples like BCG and MMR, which we'll come to later on. You could take the whole bug, whether it's a virus or a bacteria or something else, and kill it. So it can't cause problems in the individual, like an infection, but it can present all its little bits to the immune system and fool the immune system into thinking that there's been the infection. Or you could use bits of that bug, whether it's virus, whether it's bacteria, whether it's something else, bits of protein, bits of polysaccharide, put that into a vaccine. Now, for the whole killed organism, and particularly for the protein or other subunit, it might not stimulate the immune system enough because it's dead or it's just little bits of it. So there's often something called an adjuvant, which is added to a vaccine. And that is purely there to make the immune system wake up and recognize the bits of protein or the killed bug that's there. Now, more recently, we've got other types of vaccine. We've got viral vectored. Now, that's taking a virus, usually a fairly innocuous virus, and in it putting that a little bit of what you want to protect against. So the vaccine bit, into that virus. That virus is then given to someone, and as part of its replication cycle, the little bits that you've put in there appear for your immune system to recognize in the setting of an infection. So you don't need an adjuvant. Now, those viral vectors could either be what's called replication competent, so they do replicate within you and could potentially cause symptoms, or more likely replication incompetent, which I'll come to later on. So in other words, they can't cause an infection. It's just packaged into a virus, the bit that you want, and it stimulates the immune system, almost like the adjuvant does. And more recently, we've got mRNA vaccines in the setting of COVID, which I'll come to later on. So will the vaccine cause side effects? Well, we can split the vaccine into the two main bits. There's the main vaccine component, and there may or may not be the adjuvant. So the main vaccine component, the key bit, is whether it's live or non-live, or like I've already said, replication competent or non-replication competent. If it's non-replication competent or non-live or dead, then it can't cause an infection in someone. So we can forget about that. But if it's replication competent, then depending on someone's immune system, it may cause problems. What about the adjuvant? Well, the adjuvant isn't going to cause an infection, but it could potentially cause problems. It's there, as I've already said, to encourage an immune response. And it's possible that that immune response may not be something that you want to be encouraged. And very rarely there might be occasional issues with other things that are within the final vaccine products, like preservatives or whatever else. So let me talk about these live or replication competent virus vaccines. They should not generally, without a lot of thought, be administered to someone who's significantly immunosuppressed. And examples here, BCG, the live attenuated influenza, not the routine influenza, but other ones. MMR, or the components of MMR, oral polio, oral typhoid. The normal type of typhoid vaccine is absolutely fine because it's not live. Smallpox, the current varicella or zoster vaccines, yellow fever, all of these are live. Now, if you've got someone that you're putting on biologics or you're going to be giving long-term heavy-duty immunosuppressants to, then actually you should think twice before giving any of the vaccines listed here, because they could potentially cause problems. In me or in you, it's not going to cause a problem. We know that MMR is unlikely to cause any significant issues, but if you haven't got much of an immune system, it potentially could do. So again, discuss it with your local experts. Or you can look up what's called the Green Book, and that'll give you guidance. For instance, if you've got someone who's HIV positive, it'll say you can give MMR if their CD4 count is above 200, etc. So guidance is in there. And what about the adjuvant? Well, I said potentially it could cause a problem. Now, this is more theoretical than practical, so I don't want to put you off at all. But the adjuvant is there to stimulate an immune response. What about if it stimulates an unwanted immune response? What about if you're actually giving immunosuppression because you want to control an immune-mediated disease, perhaps MS, etc.? So this is something you might read about, but actually it's not been shown to be an issue. We're keeping an eye out for it, but it shouldn't get in the way. So that other bit, will the vaccines work? Well, I've said vaccines work by stimulating an immune response. So if you've got a poorly functioning immune response, maybe because of the treatments you're giving someone, will the response to the vaccine be sufficient? Well, actually, unfortunately, we've got relatively little data. And that data we have can sometimes be really confusing, because how do we define what an adequate immune response is to a vaccine in terms of blood tests or other tests? We could look at the antibodies, we could look at your T cells, one of your compartments of your immune system, we could look at other bits, but which bit do we look at for that infection, and what's the threshold? What's it's okay and what's it's not okay? And we don't really have that data. What we have is data of giving people vaccines and just seeing how much flu they get, how much COVID they get, etc. So what about general advice about vaccination? Well, all patients that you're seeing should have, and particularly those receiving biologics, but even those potentially not receiving biologics, should be vaccinated against pneumococcus, a common chest infection. They should receive the inactivated influenza vaccine every year. That's the common vaccine that's used for influenza, and it needs to be given every year. And they should be considered for Hep B vaccine if they're either Hep B non-immune or they're otherwise at risk of reactivation. Other vaccines that don't contain live virus or replication competent viral vectors, etc., should be given as the routine schedule for anyone, the same as the general population. You might say, well, why are you telling us? Maybe we know that we should be giving people pneumococcus or advising them to get pneumococcal vaccination, or they should be getting their annual flu vaccine. Well, I want to reiterate this, even if you know it already, because we're not very good at it. Now, I haven't got any data from MS, but I have got data from rheumatologists who use an awful lot of biologics. And they say, oh, we're really good at this. We advise everybody to get these done. Now, you may not be able to see this well, so I'll talk over it. If you look at a large series of individuals in clinics with rheumatological problems who were advised to get flu vaccine and who were advised to get pneumococcal vaccine, only about 85% of people received the influenza vaccine. It's not too bad, but it's not 95%, is it? And if we look at the pneumococcal vaccine, actually it was between 40 and 45% who'd actually received and followed that advice. And even of that 44% here that have had pneumococcal vaccine, they may well not have had the right pneumococcal vaccine. Again, the detail in this isn't important. It's just to show that it's a little bit complicated. Actually, most immunosuppressed people would benefit from starting off with Prevnar and then having Pneumovax later on. But I can almost guarantee that if you just ask the GP to give the pneumococcal vaccine, they've just had the Pneumovax and not Prevnar. So there's a lot of work we still need to do to protect our patients better than we are. Varicella and zoster is an interesting one because it's just becoming more and more discussed and more used. So that's chickenpox and it's shingles. Now, we have a live vaccine called Zostavax. Is it safe to give? Well, it's a live vaccine, so actually if you've already got someone on the immunosuppressants, no. Potentially you could use it a few weeks or a few months before you put someone on immunosuppressants. Does it work? Well, the efficacy in the immunocompetent, people with a good immune system, is maybe 50 to 70%, so it's not perfect. And actually, what about data in the immunocompromised? We don't really have it. Now, there is something called Shingrix, which will hopefully become more available in the UK in future months and future years. This is not live, it's a subunit vaccine, so it is safe to give. The adjuvant has theoretical potential to worsen autoimmunity, but it's been looked for and hasn't been seen as yet. And good efficacy has been shown, and perhaps good efficacy in the immunosuppressed. So things may get better in the realm of preventing chickenpox, or even those that have had chickenpox in the past, preventing them having shingles. What do you actually do in practice though? Are you yet screening people to see whether they're Varicella zoster virus IgG positive? There's evidence they've had chickenpox before, in which case you could give a shingles dose vaccine, or indeed they're negative, in which case you could actually give them the Varicella dose of the vaccine. And are you vaccinating on the basis of that? And I just want to take a slight tangent at the moment. And who else should you consider vaccinating? Because people forget this. So you might have someone with MS you're going to be giving biological agents to. There is a logic in actually making sure their household and their close contacts are also vaccinated. Because if they bring the infection into the household, your patient might get it. You can prevent them bringing in pneumococcal, bringing in chickenpox, bringing in some of these other things by making sure they're vaccinated appropriately as well. But not with the oral polio vaccine, because actually that is a live vaccine, and even if it's given to a household contact, there's a slim risk with this that it could be transmitted to your patient. So, topic of the day, topic of the last 18 months, what about COVID? It's been really what I've been working on almost full time over that last 18 months. COVID vaccination. So what about Bob and what about COVID? Well, which COVID vaccines do we have in the UK? Well, we've got a few, and I've listed the manufacturers, and we've got quite a lot of other ones which are investigational, so we've got quite a lot of choice. The important bit, safety-wise, is none of them are replication competent. Two of them that we use so far are viral vectors, but they're non-replication competent viral vectors. So none of them can cause COVID, can cause an infection, can cause a problem in your patient. And none of them have an adjuvant. So there's no extra specific safety concerns in your patients. What about efficacy? Well, actually, last week we've got data from the Octave study. There are particular concerns that some people may not develop good immune responses to the COVID vaccines. Now, rituximab, that agent I spoke to earlier on that knocks out B cells, actually, after 2 doses of COVID vaccine, almost 90% of people still had low antibodies, probably insufficient response. What about people on biologics? Well, this gave us data on inflammatory arthritis. 50% of people still had low antibodies. Hematological malignancies, solid organ transplant individuals, all these individuals are people that we suspect, and we're getting more evidence like here, that they get an insufficient response to the vaccines we've given so far. And there could be an impact on more gentle immunosuppression, even steroids. If we think about the variants of concern, actually a little bit of a difference to the immune response to them could make a difference on whether someone catches a variant of concern or indeed ends up in hospital because of it. So what can we do? Is there one vaccine which is better in the immunosuppressed than another? Well, we have no data yet. Could we give boosters and different schedules? Well, the answer is yes, almost certainly we can, and there are studies ongoing at the moment to tell us how best to do that. At the moment, though, it's only those 2 doses that are on offer to your individuals. But there is another route, monoclonal antibodies, which bypass the need for an immune response, and actually you're just giving people by an intravenous infusion or maybe intramuscular injections the antibodies directly that protect them against COVID. And this may be important for some people. And just recently, the Provent has given a press release saying that with their agent, 77% protection against catching COVID. So there are other routes we can do, even for those very heavily immunosuppressed people. So what's my current advice? Try the vaccines, whatever's offered. There's no safety concern, but it may not work. Persist with the other protection strategies if they are immunosuppressed, shielding, etc. And if they're very immunosuppressed, consider giving monoclonal antibodies when they become available. Though monoclonal antibodies may get in the way of a response to a vaccine. So give the vaccines first, monoclonals later on. What about travel? Just very quickly. So you're doing a good job with Bob. You've got his MS a lot better. And what he wants to do is he wants to travel. And he wants to go to Acapulco, or he wants to go to South America. What advice can we give him? Well, certain vaccines related to travel, absolutely fine. Typhoid, rabies, cholera, all okay. They're not live, the non-oral typhoid. What about yellow fever? That is live. You've got to really consider this and get specialist advice. So on the question of specialist advice, what advice do you give your patients pre-travel? Book into the high street pharmacy, book into the GP, book into a general travel clinic, book into a specialist travel clinic, or do you sort it out for them? Well, the answer should be one of the bottom 2, book into a specialist travel clinic or you potentially sort it out for them. Because the others, the first three, won't have enough specialist knowledge for someone on biologics or immunosuppression. But do you know where your specialist travel clinic is? Do you know where to get advice from? Well, there will be a specialist travel clinic somewhere, maybe in your hospital, maybe somewhere else. Maybe scout it, find out about it. There are health lines, there's something called NATHNAC, which can give you advice as well. Just finishing up, so what about other travel advice? Malaria. Is it going to be worse for a patient on biologics or immunosuppressants? Well, the answer is who cares, because it's really serious anyway. Make sure if someone's going to a malaria zone that they have antimalarials. Doesn't matter what treatment they're on, absolutely everybody needs that. And the other thing just to highlight that could be worse in your patients on immunosuppressants or on biologics is traveller's diarrhea. It's more common, it can be worse. So advice about food and water hygiene, etc., really important. Anyway, let me stop there and I'll be very happy to answer any questions. I hope that was of use to you. Thank you.